Hi, my name is Peter Gliatto, and I'm the Associate Dean for Student Affairs, and I'm going to be talking about a session that I went to at this year's AAMC annual meeting in Philadelphia about the student surveys that the AAMC administers. This session was given by these folks, Thomas Koenig, Douglas Gerbeck, and Marie Caulfield. Tom Koenig is the Associate Dean from Johns Hopkins, and Douglas and Marie are staff members at the AAMC, I believe, and they are part of the Student Survey Advisory Committee. And they presented the work that a large committee made up of many members from the AAMC from multiple constituencies came together and decided about what future directions they are taking on student surveys. So as many of you know, currently the AAMC administers 3 separate surveys to students. One is the post-MCAT student questionnaire that's given within 3 weeks after a student takes the MCAT, so these are pre-medical students. It also gives a survey to students as they're matriculating into medical school, so the summer before they start first year, and that goes to all accepted students across the country. And then the one that we may be most familiar with at our school is the GQ, the Medical Student Graduation Questionnaire. That's given to all graduates, and it's administered in the spring of their final year. And these are very important data that allows us to self-study our processes, aim to what we need to improve upon. It's very important for accreditation. Accrediting bodies like the LCME are very interested in how we perform, in especially the GQ survey, for policy development, and for national benchmarking, because when we get the data from these types of surveys, we can see how we've done from year to year if the questions have stayed the same, and we can also compare ourselves to national averages. So the Student Survey Advisory Committee looked at all of these surveys and looked for ways to improve their output because they know schools like us use them for important high-stakes decisions. So they looked at all the surveys and decided about relevance and getting rid of obsolete questions, because many of these surveys are quite long, and adding new relevant topics. Timeliness, about when to ask the right questions. Quality and aligning for continuity, asking students similar or the same questions across these surveys, because then you can follow cohorts over time. What they realized is that they have a snapshot of students as they enter school and as they leave school, but they really don't have a sense of what students are thinking about school while they're in the middle of it. So they are going to develop a new survey, a 4th survey that they're calling the Medical Student Life Survey, which they've also called the Y2 survey, that's going to be focusing on early medical experiences, the learning climate, and well-being. So once all these surveys are done and running, this is what it'll look like. There'll be the post-MCAT, which is the far left column, the matriculating student questionnaire, the Y2 survey, or the student life survey, and the GQ survey. And you can see where there's overlap. For example, the first 2 surveys are going to really look at preparedness for medical school, what were students' key influences in deciding to pursue medicine, what kind of things they do to make themselves viable applicants through work and volunteerism. And then there's going to be broad themes that extend across several surveys. For example, the MSQ, the Y2, and the GQ will all look at things like well-being and empathy, mentoring experiences, utilization of school resources, whereas Y2 and GQ will be focusing more on certain things that are specific to medical school, like curriculum, competencies. And then there's certain things that will span across all 4, specialty choice, and indebtedness will be something that they'll look at the end of college and the end of medical school. So in terms of reformatting and piloting these surveys, here's what their plan is. This past year, they piloted they started a new post-MCAT questionnaire, and they revised the matriculating student questionnaire and piloted that. And then they piloted some questions from the student life questionnaire, the Y2 survey, and I'll go through that data in a minute. This upcoming year, the plan is for the new matriculating student questionnaire to be completely ready to go, and they're going to pilot some new items on the GQ, and they're going to pilot the new Y2 survey in its entirety. In 2015, the Y2 survey will go live, and they'll pilot the new GQ items. In 2016, they'll pilot the new GQ survey, and then by 2017, the new GQ will be administered, and by that point, they'll have accomplished what they set out to do. So let me talk a little bit more about the Medical Student Life Survey and what they have planned. So they piloted, not the full survey, but they piloted questions in spring of 2013. The plan, once it's up and running, is that it'll be administered in the fall of year 2. As you imagine, the spring of year 2 is not a great time to ask student questions because they're preparing for step 1 and they might have a different take on their medical experience. By the fall of year 2, students have been in med school long enough to understand the climate of the medical school, the resources that are available, et cetera, and they'll be able to sort of answer some things about the school that a matriculating student wouldn't be able to answer, and a graduating student may have a different perspective on. So they're testing a question about a student's sexual orientation. The reason they asked about that, they said that was something they were encouraged to do by a number of groups, including the AAMC's Group for Diversity and Inclusion. And I think they're really looking at how these students experience med school and what resources they use. They're testing items that measure learning climate, student well-being, stress, empathy, quality of life, and drug use. And again, they're going to try to use the results and questions that are similar to the matriculating student questionnaire and the graduating questionnaire so they can track students and cohorts over time. So a little bit more about what these domains are about. They're asking about learning environment and experiences in this Y2 survey. They're using a couple of different scales. They're looking at the emotional climate of the school. They're looking to see how students interact with faculty and how students interact with each other. Some questions that get at the hidden curriculum or the informal curriculum, and some questions about how cultural competency is taught and modeled. There's also questions about empathy, particularly perspective taking and empathic concern, and I think the interest here is to see how these skills change over time. There's a perceived stress scale that will be administered. Students will be asked about their social supports and mentoring, about their overall quality of life. And I mentioned drug use before, I think particularly use of stimulants that are diverted to students, which has become an issue with schools recently. So they piloted this year these questions. A survey link was sent to all students who were in the second year class. As you can see, they sent it to 19,000 students. It was anonymous. And they sent 3 reminders between April 15th, 2013 and May 17th. They only got an 18% response rate. Their respondents they felt was not representative of the cohort. Females were overrepresented, whereas Asians and underrepresented in medicine were underrepresented. Of note, 99% of respondents did answer the sexual orientation questions, and they asked for respondents to talk about their experience with the survey, and they received largely positive comments about that. So in terms of the future, they will be piloting the full survey this upcoming year, and then the full survey will start in the fall of 2015. So that's when the survey will truly go live. I feel it'll be an important measure of accreditation. It's going to be something that LCME is going to be looking at for sure, and it'll really be a good internal measure for us to look at this data. It really gives us insight for what it's like to be in the middle of the medical experience, and I think it's going to be qualitatively different than the GQ, and it'll be helpful to track data over time. One concern I have is that these are lengthy surveys. They take about an hour to fill out, and I think students are really subject to survey fatigue, having to fill out all these surveys, plus the ones that we administer to them, and research studies and things like that. So that's something that we'll be cognizant of. And these surveys are not, we can't mandate that students do these surveys, so we have to think about ways to incentivize students effectively to fill them out. Thank you for your time, and I want to thank the Department of Med Ed for supporting my trip to Philadelphia.
So the next topic we're going to talk about is core entrustable professional activities for entering residency, and this was developed by the AAMC Medical Education Cluster and was launched at this year's annual meeting. So if we think about the continuum of development of a physician, we can think of these very key transition points that happen for physicians. One is that you can move from college to medical school. That's a big transition point. The other is medical school to residency. Of course, you can think of many others, things like the transition between residency and practice. And one of the key transition points is this graduation from medical school to residency, because it really moves the trainee from very much supervised practice and to a phase where they are now really entering a practice where they will eventually be independent. And so program directors across the country have expressed some concern about how students are prepared for that first day of residency. And so the AAMC convened a panel of educators between January and October of 2013 to try and really think about what are the activities that all entering residents should be expected to perform on the first day of residency without direct supervision, meaning that there would be nobody present in the room when they actually conduct those activities. And they decided to use activities in the context of what are referred to in the literature as entrustable professional activities. And these activities are elements of professional work. They are like the day-to-day units of what you do as a professional. And they're not everything. They really are what is considered critical elements that form the meaningful core of what you do as a physician. Now, in distinction to competencies, which are often described as knowledge, skills, or attitudes, activities really are more of an overarching term. And they would in some ways be, an easier way to think about them is that competencies really are descriptors of physicians, right? So you might say, as a physician, I have this set of knowledge, I have these skills, and these are my attitudes. Whereas entrustable professional activities are descriptors of work. For the purposes of this group and for groups that work on EPAs, the activities must be independently executable so that a person should be able to do them themselves. You should be able to observe the activity, and they have to be measurable. If we have any assessment that needs to be conducted, then you have to have these criteria for each activity, or else you're not going to be able to make a decision about whether somebody really can execute that activity or not. What's really interesting about the term entrustable professional activities, which was developed by Olent and Kat from the Netherlands, was this notion of trust, right? And trust is really quite built into the profession. Patients have to trust us. The system has to have trust in the fact that we can independently practice. And so the idea of trust is pretty much a central concept for physicians. And so EPAs really adds this notion of trust. It also explicitly adds the term supervision into the assessment equation, in that in order for me to make a decision about whether someone is trustworthy, I have to actually be able to observe it, to measure it, and then deem them entrustable for that particular activity. What also is a big part of EPAs is the idea that the supervisor has to infer the presence of multiple competencies. So in the competency framework, you assess someone's knowledge, or you assess a particular skill or a particular attitude. But here you have to sort of link a bunch of things, because these activities really bring together knowledge, skills, and attitudes. In order to carry out a core activity, you have to integrate knowledge, skills, and attitudes in order to perform it. So the supervisor really has to infer multiple competencies in order to determine if someone is able to perform that particular activity. And by putting the supervisor in a role where they need to document and acknowledge that the trainee has demonstrated that competency to conduct that activity independently, it really puts a significant responsibility on the supervisor to really do that accurately, to say that if this person's ready for this activity, I have said with fair confidence that I do not need to be in the room when that person does it. So that the reason these has become more a part of training is that it really puts a different level of responsibility on the supervisor or supervisors, and it really brings into account the fact that activities require different competencies in order to sort of be conducted by physicians. So the AAMC for the EPAs for students, for graduating students, came up with 13, and the next 3 slides just basically talk about the 13. They were to gather a history and perform a physical exam, to develop a prioritized differential diagnosis and select a working diagnosis following a patient encounter, to recommend and interpret common diagnostic and screening tests, to enter and discuss patient orders and prescriptions. And if you look at even these first 4, you get a sense that these are activities. They encompass different knowledge, skills, and attitudes in order to do them, and they are rather broad, but they're also measurable, they're also observable. And under them, you can imagine several subdomains that really comprise the activities, and I'm going to show you an example of one of these that's broken out. The next 4 provide documentation of a clinical encounter in written or electronic format, provide an oral presentation summary of a patient encounter, to form clinical questions and retrieve high-quality evidence to advance patient care, and to give or receive a patient handover to transitional care responsibility to another healthcare provider or team. The last 3 are to participate as a contributing and integrated member of an interprofessional team, to recognize a patient requiring urgent or emergent care, initiate evaluation and treatment, and seek help, and to obtain informed consent for tests or procedures that the day 1 intern is expected to perform or order without supervision. And something like that can appear to be very broad, because what does that mean? There might be a tremendous variability in what one of us might expect at one program compared to another, but the document offers some examples, things like getting consent for a central line, or obtaining consent for a radiologic procedure requiring a dye. Perform general procedures of a physician, another very broad category which might differ by program. And here the examples given are things like mask ventilation, basic life support, venipuncture, and PPD placement. And finally, to identify system failures and contribute to a culture of safety and improvement. So looking at these 13, you can see that some of them are pretty broad. Some of them are things that you might identify with as appropriate. And this was basically a consensus document of 13 developed by the medical education cluster that the AAMC brought together. So to give you an example of what happened, the EPAs were then expanded. And these 13 EPAs, they tried to further describe them using the critical functions of the activity. So what does that overarching activity constitute, so that a program or a medical school can really sort of break it down into components for students to really think about how to master. And the other thing they did is try to map it to the ACGME competence domains, and that was in an effort to really, I think, bridge the continuum of medical education. In the past, there's been this historic divide between undergraduate medical education and graduate medical education, and I think what the cluster sought to do is to map it so that you can think of training more longitudinally. So here's an example of expanding and breaking out one of the 13 EPAs. So the one we'll talk about today is recommend and interpret common diagnostic and screening tests. So here's the breakout. It talks about recommending first-line cost-effective diagnostic evaluation for a patient with an acute or common chronic disorder as part of a routine health maintenance. So you could potentially think about, when you develop curricula or assessment, how are you going to achieve that in your medical school for all your students? How are you going to assess that a student is able to provide a rationale for the decision to order the test? Incorporate cost awareness and principles of cost effectiveness in developing diagnostic plans. To interpret the results of basic diagnostic studies and know common lab values, and understand the implications and urgency of an abnormal result to seek assistance for interpretation as needed. So by expanding each of the EPAs, they've provided programs with a detailed description of the approach to finally accomplishing this. And as you can imagine, each of these would probably mapped out in a curricular blueprint to what's taught and how it's assessed among a student, such that at the end of their time with a school, you would be able to certify that your graduating student can recommend and interpret common diagnostic and screening tests, and a program director can be relatively sure that the student you are handing over to them on day 1 of residency without direct supervision can be counted upon to achieve that activity. And the second thing they did is map it, as I mentioned, the ACGME competencies. And for example, this particular EPA was mapped to patient care, to medical knowledge, to practice-based learning and improvement, and systems-based practice. So what are the next steps at the AAMC? The EPAs were presented. This is not a requirement for medical schools, and they do not anticipate that this will be linked to accreditation at any point. This was put out as an effort to try and encourage schools to think about measuring students in terms of activities, and then being able to confidently pass along a student to a GME program to reassure program directors that they have the basic skills that would be expected of a day 1 intern. So they are accepting additional feedback from stakeholders on the EPAs, so there might be some modification to those 13. And then after they finalize them, they are probably going to start a pilot program to test them at various schools through the development of curricula and assessments. And I think they will just look for schools that are interested in pilot testing. There was a fair amount of discussion at this session about what this means for schools that have developed their own objectives or have moved to a competency-based model, and what schools would be required to do. And I think the general thought that the AAMC offered was that this was not supposed to be prescriptive. It was supposed to be offered to schools as an opportunity and was not meant to force schools to adopt EPAs for their medical students.
I went to a bunch of sessions, but I picked one that I thought was fairly interesting for the group, and it was called the Khan Academy for Pre-Health Preparation, the MCAT 2015 exam and beyond. So let me give you a little bit of background. Last year, so not this past November, but the one before, at the AAMC meeting, there was a large session about the work of the Khan Academy. And for people who don't know, probably most people know what the Khan Academy is in the room, but for people who don't, it's a not-for-profit with the goal of changing education for the better by providing free world-class education for anyone, anywhere, and essentially has, on the web, numerous educational videos and resources. Hundreds of questions and videos, community forums where learners and teachers can post answers, educational games, and interactions. So that's what the Khan Academy is, and that was a huge session at the 2012 AAMC. Further background for people who don't know is that the MCAT will be completely new in 2015. Right, so those are two things that have really nothing to do with each other necessarily. What's happening with the MCAT? The MCAT is adding biochemistry. The MCAT is adding an entire section on behavior and social science. So a lot of the students are feeling as if they need to know psychology, sociology, some anthropology, right? A whole new session on behavioral science, so that and it makes sense that we would want our physicians of tomorrow to know about seeing the patient, sort of the context of them as a person. And they're also taking away the writing sample, and they're adding a bunch sort of throughout the questions called critical analysis and reasoning skills, which is essentially getting at sort of looking at information in a scholarly, research-oriented way and asking a lot of sort of critical thinking throughout all the questions. So the MCAT is evolved, and that will start in 2015. So at the Khan Academy session at the AAMC a year ago, 2012, a year and a couple of months ago, the audience members came up after the session, and there was sort of an overwhelming desire asking for the Khan Academy to help pre-health students, so pre-med students around the country, prepare for the new MCAT. So does that make sense? That was sort of where the connection of these two backgrounds came together. And actually, what I found so fascinating is that it happened. So, right? So something happens at a meeting in November of 2012, and by April of 2013, the AAMC and the Khan Academy and the Robert Wood Johnson's Foundation announced a collaboration to provide free online resources to help students prepare for the MCAT. Which is phenomenal, right? And they got a grant, and Robert Wood Johnson was paying for it, and the Khan Academy was doing their thing, and the AAMC was endorsing the whole thing, right? And so they had a sponsored competition. And in June of 2013, they had video submissions from pre-med students and from medical students and from residents and from faculty members teaching on topics that are important for the new MCAT. And they basically brought winners to the Khan Academy, and at this session they had a couple of the winners of these small videos. And these videos are short, 3, 5, 7, 8-minute videos on a topic. And so the tutorials are now available through the Khan Academy Online Learning Library, as well as the pre-health collection of AAMC MedEd portal called iCollaborative, and they're free. And they're searchable, and it's an online repository of instructional materials. And the scale of what they're doing and how many people have had hits, and of course this goes back to sort of admissions not necessarily totally understanding what's happening in IT, but the scale of what they're doing is, 200 countries, 4,000 classrooms, 10 million monthly users. I mean, it's unbelievable, right? So what did they, so part of this session, and it wasn't long enough actually, I would have liked it to be longer and to heard more about what that resource and that scalability is, but a lot of what it was about was teaching the people in the room what a good video, what are the attributes of a good video? And basically that the teacher has to be authentic, has to be clear, has to be engaging, has to have rich content, and has to have pace. And they split us up and they made us teach each other something, which of course is always makes me anxious, but you know, because you're with people you don't know in this room and you just, right. So, but they basically sort of showed that the kid who had won, one of the kids who got sort of the free weekend at the Khan Academy and for his video to get better and better and won the competition, one of them, many won, basically showed what materials he had used like in his room, and it was like his little laptop, like a microphone that looked a mess. You know, it was really low tech in a way, but yet it was getting all these hits on the web. So they taught us those things, which are sort of obvious, but again, I think sometimes we go in learning and teaching too quickly to, you know, PowerPoints and a little bit, you know, too much content, and it seemed better to have ones that were short and engaging with a quick pace and a lot of content quickly and short. So why did I find this so amazing? It clearly allows for educational access across the globe, right? No matter who you are, no matter where you are, no matter your resources, no matter anything, right? It gets quickly at sort of educational debt because it, again, there's a huge, one of the fears in admissions right now is that without the schools teaching the content necessarily, the pre-med schools, the undergraduate schools teaching the content that's on the new MCAT, it's sort of fueling this whole expensive test-taking market strategies, right? So, okay, well, if I don't have the sociology that's needed for the MCAT at my college, if I don't have the psychology, if the stats class is not exactly for the MCAT, I'm just going to take the MCAT course, which of course increases debt and decreases access. So this decreases debt and increases access. So I thought that was phenomenal. And then it's global, and I just thought it was so innovative with respect to sort of educational materials not being your resource, but being the world's resource. So to me, it was fascinating.
I'm going to be short and sweet. I wanted to share with you some things that I thought were relevant to a lot that's going on here at Sinai. Number one, there were actually a few sessions on mergers and acquisitions, which I thought was quite timely since the meeting occurs in November, and we were just on the beginning stages of how to think about merging with the folks at Continuum. So this particular session involved 4 institutions that merged, and each of the institutions had a representative that shared some of the barriers, some strengths to the process, some things they wish they had done better. And they were all very different institutions. So Walter Reed Hospital and the National Naval Medical Center, which I thought was fascinating because as a civilian, you know, you don't realize the intricate differences between all of the armed forces and things that the culture of those institutions and the differences between those two environments. And I was struck by the difficulty that they faced merging the culture and processes because this hierarchy is very different. You know, from an outside looking in, it seems like it's all the same to me, right? The chain of command goes up the chain, but these two institutions really struggled culturally. That was their biggest barrier. Second one, UCSF and Children's Hospital of Oakland, their largest barrier, which I thought was fascinating and very relevant to us, was faculty acclimation, right? So titles, salaries, job descriptions that meant various things at each institution. So the director of a program was different than the manager of a program, which was different from the coordinator of a program, which was different from chief of a service. So all of those things and how they worked through really being able to satisfy their faculty base, and also keep true to the mission of the institution that was taking over, which was obviously UCSF taking over the other institution. And so I felt like that was extraordinarily relevant to us here because we're grappling with some of that as well. The third system was also, I think, relevant, even though we're very different, but Greenville Health System was basically taking over 4 local community hospitals in that area. And so the level of care, the connection to those communities, what it meant for the big guy on the street to come in to and impose their culture and processes on some of those relationships was quite interesting as well. And then I thought was very fascinated by the fact that all 3 of these institutions took 3 to 5 years to fully integrate their systems. I was struck by that. I feel like Shashi and I have been on a 6-month plan, 6 months to full integration. So I felt, I guess, a little bit of, I felt encouraged because we have done so much in the short time that we've been engaged in this process. And despite the fact that there's still a long way to go, I think that we will certainly be ahead of that curve. Also being proactive about the culture, which is something else that I felt that we have really tried to do a very good job at both, and I'm speaking strictly on the education side, UME, GME, CME, because I'm less involved in the hospital institutional discussions, but I felt that we've done a really good job at understanding the culture and trying to be respectful and generous as it relates to process and systems and understanding what people are connected to emotionally and valuing their input and bringing them into an engaged conversation. So I feel like we've done a really good job, and almost all of those other presentations discussed areas where they did not do that well. And so I felt like, again, we were ahead of that curve. And then communication strategy, which I also dovetails off of what David was just talking about, utilizing all of those folks in your broader team to make sure that messaging, communications is not only timely, but also proactive, right? So letting people know what's coming down the pike. And I also felt that we were doing a really a pretty decent job in that regard as well. And so I guess I left that session feeling like we're on the right track, that we're thinking about some of the things that everybody else in the country is thinking about. And then another thing that struck me was over the last 3 years in the United States of America, over 200 institutions have merged in the US. I was fascinated, academic medical centers. I was fascinated by that number. I didn't realize that this was such a prevalent and growing trend in the country. The last session that I wanted to report back on was the session on data, benchmarking and data collection, and using the AAMC as a resource for all of us who are interested in looking at, you'll see what data I'm speaking of, but a variety of different types of data sets. And most of the information I'm going to talk about is really is for public information, so anybody can access it. And those areas that are a little more restricted can be accessed through me or my office. So if anyone here is interested in any of this educational data, whatever I can share with you, I will. So institutional data, as it relates to medical school tuition, financial aid, teaching hospital finances, medical school finances, curriculum, the mission of medical schools. So all of these areas, there is a tremendous amount of data collected by the AAMC from all academic medical centers in the country. And so, quite a few of us are engaged in, whether it's reform programs or changing our curriculum or kind of understand what our sister institutions are doing. There's lots of data available to us to really benchmark what we're doing and to make sure that we're kind of thinking about things in a similar way. And again, if you have questions about access to this information, I'm happy to share. Compensation data, right? So faculty compensation, demographics, type, so demographics including race, ethnicity, gender, geographic location, type of specialty, MD versus PhD, so all kinds of data as it relates to that, and applicant, student, and resident data, which all of you in the room, anybody who's been to medical school, anybody who took the MCAT is currently in this data set. So we all have access to any of you in the room that have taken. They keep, and they track. Yeah, since the MCAT began, I can contact the folks in the data office at the AAMC and get specific. I'm not going to get name data, but I can get aggregate data. So people who took the MCAT in 1972, and we can find out where they are, what type of position they have, whether they're in academic medicine or private practice, what's their specialty, whether they're boarded. I mean, it is quite an exhaustive set of data. I was quite impressed with that. Also, as it relates to applicant, student, and resident data, so the AMCAS data, ERIS data, so for those of you that don't know ERIS, Electronic Residency Application Service, so anybody who's ever applied for a residency through this system, data is there for them. Student surveys, so very student-centric information related to anything from educational experience to debt to mistreatment. So all kinds of information is contained in those documents. Those documents were a little more selective about how we share, and we can share some aggregate information, and are happy to talk to you about that if you want to reach out to me. GME census data and student records data, right? So what is the attrition? How many students that enter, graduate in 4 years? How many students do a scholarly year? So all of that kind of information that I really, that I think many of us would find quite interesting. So if anybody has questions or is doing a project and would like information or access to some of these data sets, please reach out to me as the gatekeeper. I don't have all of the data, but I can access any of it if you're interested. Yeah.
Hi, everyone. So I have a question for everyone, is that who here has heard of implementation science? By show of hands, anybody? Anybody read anything on it? Good, so I'm glad I picked it because, so the AAMC has a few years ago decided that implementation science needed to get out into the med ed world. And this was a symposium that was there called Implementation Science Symposium that I was involved with. So full disclosure, I was involved with this one because I'm actually on a task force for the AAMC looking at implementation science and med ed. So I thought maybe bringing something that is really on the forefront of where the AAMC thinks we need to go would be helpful. So just to put it in perspective here, thinking, for the clinicians in the room at least, thinking about a patient with diabetes, hypertension, hypercholesterol, and OA, who consistently presents with elevated hemoglobin A1Cs and elevated blood pressures. So everyone who takes care of patients knows that frustration, right? And the thing is that Mrs. Rosario is one patient, right? But when this now gets expanded to hundreds of thousands of people, it's a public health problem, right? And we know that by not having those two cardiovascular risk factors under control, that there will be bad patient outcomes. But the evidence exists. We know the evidence that they all should be controlled, right? So that is sort of the background of thinking about this and realizing that clinical practice is complex and very multifaceted, right? It's not as simple as a randomized controlled trial that says, you do this and these perfect patients don't do this, and then we come out, we have the outcome, we know hemoglobin A1C should be less than 7 or whatever, or 8 in an older patient. So that's the backdrop. So, so this field of implementation science has been taking off. It's much more popular or well-known in Canada and Europe, especially the UK. And the most well-known definition right now is by this Dr. Eccles. And it says, this is the scientific study of methods to promote the systematic uptake of research findings and other evidence-based practices into routine practice, and hence to improve the quality and effectiveness of health services. The key here is that this is to be implemented in routine practice, in the complex routine practice. So implementation science looks to emphasize the adaptation and testing in real-world settings. So this is actually real, rigorous science, but it's implemented in the real IMA clinic, in the real PEDS clinic, right? And in diverse populations. It is meant to be implemented and evaluated in the actual practice environment, determines its effectiveness, without having control groups that are maintained in such a way that they don't represent actual patients, because that's where they felt the gap is. It's a study of what happens after adoption occurs. So everyone reads about this in JAMA, they read about whatever, but it's actually what happens after that in the complex organizational settings of how we get things so that Mrs. Rosario can be taken care of well. And it examines to what extent these interventions are successful within a real-world context. Okay? So some terminology that you might hear, this is other terminology that you might have heard, okay? But implementation science is now being touted as the word to use. So dissemination and diffusion, knowledge transfer is one that you may know, knowledge uptake, outcomes in education. So different people are used to use these words, but they've moved to wanting us to use implementation science as the terminology that looks at the context of studies. And the IS principles that are now being put up for if someone decides they want to do this, and this group that I'm working with, I will tell you that's primarily led by the PhD educator group. There is an MD's doing it too, but it's a PhD education group trying to help us see how, one, we can teach it, and two, we can implement it in our medical education practices. So the values this are the values that they have put forward as holding is rigor and relevance. But to do them in diverse, low-resource settings where you don't need a lot of money to do it, and you use data that's already available to you that's important to public health issues. One of the big concepts here is efficiency and speed. This is not something that we know starts and takes 15 years to be put into practice. This is something that you use existing data, it's in your practice, and you put small sort of changes in place and you monitor them again. Collaboration is seen as a must, and sort of the concept of team science. Improved capacity, so getting into these sort of now left, but how can we use internet in order to sort of get a lot of learning out there? And then cumulative knowledge, and how can we get consolidation of knowledge in a way that is not the 15,000 articles that you would have to read in order to get all this stuff in place. So the important issues for medical education, for implementation science in general, and med ed is it's beyond what is taught, right? So it's not the content, okay, but the context, right? What are the contextual factors that come into play, the how, the when, and the why, and in what settings your learning is occurring. And then how these desired new behaviors are monitored and supported beyond the original intervention. Because the idea is that it falls off. Things are monitored once, the grant goes away, and it does not continue. And this is an attempt to say this has to be a continual process. Some of it is related, if you think about the sort of quality initiatives, the performance improvement initiatives, the PDSA cycles with rapid PDSAs. This has similarities to that, but it's not all related to sort of quality QI and type research. So ultimately, the idea is that implementation science will inform our educational activities in order to change clinical performance and improve patient-centered care. And so the implications for us as medical educators is, one, how is this taught in our new curriculum? So in our new curriculum, we've begun to add some of these principles in there, even maybe without knowing as much, but the idea of team science, the idea of having quality and sort of performance improvement type stuff. So we've already begun. A lot of places have not even thought about this. So it's not only how do we teach our students, because this is real life going forward, but also how do we as medical educators adopt these principles of trying to understand how we can do medical education with an implementation science philosophy of all those principles that I just mentioned.